Welcome back to another episode of the NRG Oncology Podcast. I'm Lauren Henke, and I'm joined today by my co-host, Stephen Chun. Today, we'll be exploring NRG-BR008, which is a trial designed for a very specific subset of breast cancers that overexpress the human epidermal growth factor receptor 2, or as we say, HER2.
Our guests today are the principal and co-principal investigators of BR008, Dr. Lior Braunstein and Dr. Melissa Mitchell. Dr. Braunstein is a physician scientist specializing in breast cancer radiation oncology at the Memorial Sloan Kettering Cancer Center. Dr. Mitchell is also a radiation oncologist specializing in breast cancer at the MD Anderson Cancer Center. First off, I'd like to ask both of you, what exactly is HER2 positive breast cancer, and how have treatments for HER2 positive breast cancers evolved in the past decade? I remember it wasn't too long ago when Herceptin, also known as trastuzumab, the generic name, was the only targeted therapy for HER2 positive breast cancers. But it seems like there's been a revolution in HER2 targeted therapies that I just can't keep up with.
So firstly, thanks so much for having us today. This is really a great format to get to talk about the latest ongoing clinical trials and the state of the art in oncology. So thanks, Stephen and Lauren, for the opportunity. And that question about HER2 positive breast cancer is a great place to start because, as you note, it's a very rapidly moving field that in many ways has been picking up steam for over 20 or 30 years now. And at this point, it's really moving quickly. So historically, breast cancer was thought to be a single disease with a single name that all behaved rather similarly and was driven essentially by the same underlying biology, or that's what was thought at the time. But then at the turn of this century, by applying some new molecular and computational tools, researchers were able to discern clear differences between individual tumors in some of these big collections of hundreds or even thousands of breast cancers in terms of how the tumors behaved, how they looked under the microscope, what genes were on or off. And these differences gave rise to clear patterns showing what we now know, which is that breast cancer isn't really just one thing. Rather, it's a category containing several subtypes of breast cancer, and each behaves differently, and as a consequence, may also need to be treated differently. So to analogize, this is sort of how more commonly, for centuries, someone would show up with a runny nose or a cough, and we'd say they had a cold. But now we know that there's bacterial pneumonia, there's influenza, there's COVID, there's seasonal allergies, and all of these have different implications and require different treatments. So these big, historically descriptive categories, like breast cancer, these are giving rise to much more refined and nuanced understanding of very specific conditions within these categories. So HER2 positive breast cancer is one such subtype that was discovered. And as you alluded to earlier, its name derives from a feature of its behavior that also happens to be its unique Achilles heel, its unique vulnerability. And that's what's given rise to so much excitement in recent years. So HER2, as you mentioned, stands for human epidermal growth factor receptor 2. And this is the name of a molecule that sits on the surface of the cell and normally waits around to bind something called a growth factor, which is a signal that comes from elsewhere outside the cell and tells the cell itself to grow. And so we're simplifying a little bit here, but typically when the signal's absent, the cell doesn't grow. And when it's present, this HER2 receptor gets activated and it signals to some internal machinery within the cell that it's time to grow and replicate. And so in simple terms, in HER2 positive breast cancer, this signaling system has been disrupted in such a way that the HER2 receptor is overactive and it sends this growth signal into the cell whether or not there's a growth factor around from outside. And so these cells are constantly growing and dividing. And then in conjunction with a few other issues that these cells have accumulated over time, they can become cancers and grow and spread. So the key here is that this HER2 receptor molecule, and that's the one that's overactive in the cancer, is very well understood now after several decades of study. We have a very good grasp of how it looks at an atomic level from X-ray crystallography, and even how it behaves and interacts with other molecules. And so drugs have been developed to shut it off. And so you mentioned trastuzumab, or Herceptin is the brand name. That's one of the most effective cancer medicines that's ever been developed. But now there's a whole menu of these anti-HER2 drugs, all with sort of similarly challenging names like pertuzumab or trastuzumab emtansine, trastuzumab deruxtecan, many others that are in development that we'll see in the coming years. And so what we've learned is that when HER2 is shut off using one of these targeted drugs, the cancers are no longer able to sustain their growth, and in many cases, they're completely eliminated. So for example, In select situations where patients receive these anti-HER2 treatments for a few months and then undergo surgery, in more than half of cases, the surgeon finds no cancer because the treatment was so effective. And we call that a pathologic complete response, or a path-CR. So all of that is really the underlying premise for a number of clinical trials that are now reevaluating the conventional wisdom of how HER2-positive breast cancer is treated. Because it used to be a very challenging form of cancer that required many types of chemotherapy and radiation to get under control. But now with these extremely effective anti-HER2 drugs, patients do so well that we've learned they no longer need some of the other chemotherapies that they used to receive. And we're starting to question whether they even still need radiation.
So in this trial, BR008, also known as the HERO trial, it sounds like you are evaluating early stage HER2 positive or amplified breast cancer, looking at patients who receive HER2 directed therapy, either before or after their breast surgery, and then asking the question of whether radiation is really needed for these patients. Explain to us where the trial acronym HERO comes from, and can you walk us through this trial's basic design and rationale?
The HER in HERO comes from HER2 positive breast cancer, and the O comes from omission of radiation therapy or zero radiation in those patients with HER2 positive breast cancer. The basic design is that we randomize patients with early stage HER2 positive breast cancer who are how we perceive to be at low risk of recurrence, and then randomize them to standard radiotherapy versus radiotherapy omission. In general, there's two cohorts that we're looking at that we feel are both low risk. In the first cohort, we'll look at patients who are undergoing upfront surgery and found to have minimal disease in the breast, as well as negative nodes on axillary assessment. The second cohort includes those patients with limited disease on imaging who undergo neoadjuvant therapy, and then that would include HER2-directed systemic treatment as well as the cytotoxic chemotherapy. And then these patients can enroll if they achieve a path-CR on pathologic review. The primary endpoint is to look at the 7-year recurrence-free interval and see if there's a difference between the two groups. However, we'll also be looking at secondary endpoints, such as the local recurrence, the disease-free survival, and the overall survival. And then we'll also be looking at patient-reported outcomes, such as breast pain and patient-reported worry about recurrence.
And since this study is specifically asking the question of omitting radiation, we know patients who are assigned to that arm are not going to get radiation. But how about for the patients who are assigned to radiation? What are the radiation options for the patients who are selected for radiation in this protocol?
So as Dr. Mitchell pointed out, this study is designed for patients who are at very low risk of recurrence. And what we've learned from some of the trials of anti-HER2 therapy is that roughly 10 years after treatment, we expect fewer than 2% of patients to have recurrences in the breast. And that's about as good a result as we see in any cancer really across all of oncology. So these patients do tremendously well. And so what that means for the HERO trial is that for those patients who are assigned to receive radiotherapy, they can really get any standard regimen that's currently in use. So we want to enable radiation oncologists to offer this trial to their patients with the confidence that if they need to go the radiation route, no reasonable options are off the table. And so that means that whole breast radiation or partial breast radiation are both entirely appropriate, and that regimens really as short as 1 week or even as long as 6 weeks are also allowed.
To my understanding, this HERO clinical trial, BR008, has been open since the first quarter of 2023. What sort of challenges have you seen with this protocol so far, and what can be done to better support it so we can help you meet accrual goals?
We understand that many studies have a slow start, as it can take some time to get each trial through the IRB at each participating institution. However, this trial does seem to be a bit more sluggish than most, although in general, de-escalation trials are often a difficult sell for patients, especially as compared to trials that escalate therapy. Patients are much more eager to enroll in a study where new agents are added that could potentially improve outcomes. Similar challenges were initially seen with the B51 trial, which for those not familiar, that's the study that looked at whether or not patients with a path-CR to chemotherapy or HER2-directed therapy had no benefit of radiotherapy to the regional nodes. However, in the end, it was an important trial to look at, as the findings were that there was really no benefit at all of nodal radiation in those patients with effective systemic therapy. We hope to find similar outcomes for HERO And so we really need to develop better patient tools that emphasize the current excellent outcomes in early stage HER2 breast cancer and the benefits of reducing overtreatment. We're actively working on improved patient materials and physician tools for discussion of the trial in the clinic, and we hope to distribute those soon to participating sites. Another unique challenge for this study is that the radiation oncologist usually meets the patient downstream for the surgery colleagues. And oftentimes those surgery colleagues may have told the patient up front that lumpectomy always goes hand in hand with radiation. Therefore, when they get to the radiation oncology clinic and they're told they could maybe not do radiation, they're hesitant because this is a change in the initial plan that was set in motion by their surgeon. The first key visits with the medical oncologist and the surgeon are very important at establishing enthusiasm about the trial. And so really engaging the surgery team and the medical oncology team at each site is important for increasing accrual. Additionally, this is a relatively rare population, and it can be a challenge to find the patients who meet all of the eligibility criteria. We really need help to open the trial at more institutions since it is such a rare group of patients. While this may not be a high accruing trial at any one site, it is an important question that can only be answered with collective efforts by all of our member sites. And again, we know from B51 that even though there's hesitation to run these de-escalation trials, we sometimes find important answers.
I think this is great insight, and I think really speaks to the importance of a multidisciplinary evaluation of patients, rather than just, let's say, a single modality making treatment decisions. And I want to really thank Dr. Mitchell for that insight. So today we're going to do something a little different from previous episodes, something that I hope the audience finds a little fun. For this podcast, we've solicited our audience and we had a couple of questions. And for any of you listening, we usually post upcoming recordings on Twitter and LinkedIn. So if you ever have questions, please feel free to send them in to us. And so our first question is from Dr. Elizabeth Bloom, one of my practice partners who's been listening to the podcasts. Liz is a breast radiation oncologist practicing in the MD Anderson Community Campus in West Houston. She asks, what should I tell a patient who asks me, why should I risk omitting radiation when the results of whole breast radiation are so good?
So what a great question, first of all. And thanks so much to Dr. Bloom for bringing up a topic that I'm sure is near and dear to many of our hearts here as we help patients navigate some of these tricky waters with regard to contemporary breast cancer treatments. So fundamentally, I think it comes down to our role as physicians, which in my estimation means that we need to empower our patients to take the treatment route that's best for them. And so those of us who've been in practice for a little while have certainly observed that people have very diverse approaches to making their decisions about their health. I've encountered patients in my clinic, for example, who wanted to be much more aggressive about their treatment than I would be for myself. So they'd move heaven and earth and tolerate almost any side effect, really to reduce their cancer risk by, let's say, 1 or 2%, if at all. And then we've also had patients who are interested in having some treatments, but not others, and they make that decision based on what's important to them personally. So both approaches are entirely valid, of course, provided that they're made in an informed way, I'd say. So what that means for the HERO trial is that, yes, outcomes right now with radiation for early stage HER2 positive breast cancer are excellent. And for those patients who are willing to tolerate the modest inconvenience and the known risks and side effects of radiation, that's a perfectly suitable option. But by the same token, we can say that we don't have a great handle on what is the actual benefit of radiation in this situation, meaning that we may be subjecting people to this treatment where the risk-benefit ratio is not necessarily in their favor. So the HERO trial will ultimately give us that information by evaluating whether radiation truly confers any benefit for someone after they've received very effective HER2-targeted treatment. And so really, it's an excellent question, and ultimately one that comes up with any clinical trial where we're trying to determine really if an intervention is more likely to be helpful or harmful. And for this specific situation, for early stage HER2-positive breast cancer, we just don't know that answer as far as radiation goes.
In a similar flavor, we have a question from Dr. Stephen Chmura at the University of Chicago, who has recently activated BR008 at his institution. He asks, what reassures you about the potential risk of increased local failure in a population who might otherwise do so well with a radiation course like 5 days of simple accelerated partial breast irradiation. Why risk it? What's your response to that?
This is a great question. When I first started in practice, hypofractionation and partial breast irradiation were not common options. And when I'd have a patient in clinic who met the CLGB9343 trial criteria, being over 70 with early stage hormone positive disease, I frequently had patients choosing emission as I was offering them no radiation or 6 weeks of radiation to the whole breast, which was fraught with lots of side effects. These days, I offer that same patient population, omission versus 1 week of partial breast. And even without a survival advantages, the pros start to outweigh the cons for many patients, and they choose to do the partial breast radiation. I've probably changed from treating about 1/3 of those patients to about 2/3 of those patients who are eligible for remission. However, I think it's really important to reflect again on the findings of the B51 trial, where patients were selected on tumor biology and effective systemic therapy rather than just an arbitrary age. On the B51 trial, there was absolutely no benefit in local control, less than 1% absolute difference. There was no difference in disease-free survival, and survival change was 0. So really, no benefit of regional nodal radiation at all in those patients with a path CR. As the local control rates for HER2-positive breast cancer are arguably superior to those for those over 70 with hormone-positive disease, we may find that similar to B51, there's absolutely no benefit of radiotherapy in this population, not even the small 8% local control benefit that we see with CLGB9343 or Prime 2. And that may help to increase uptake of emission in this group of patients if the trial ends up being positive. Additionally, even partial breast radiation is not completely without risk. There are still patients with secondary cancers, and more importantly, there is still substantial financial toxicity. Even 1 week away from work and family could be difficult for some patients. And as a society, emission of radiotherapy in a population found to have absolutely no benefit could have a substantial impact on healthcare cost.
Again, these are such great insights. I think, we all here on this call are physicians, and we are salaried, and perhaps we could go for 5 days of radiation treatment without any meaningful impact on our income. But as you mentioned here, someone who is working, let's say by the hour, some 5 days, even for 2 hours a day or something, that's a pretty substantial hit on one's income. In any case, Dr. Mitchell, Dr. Braunstein, I want to thank you again for joining us. I think a theme that we see in NRG oncology trials like BR008 is the development of personalized patient treatment options for patients. And I think it's one thing for physicians to give patient-tailored care based on anecdote and personal experience, but this is really the real deal. Implementing patient-tailored care through a trial like BR008 in an evidence-based fashion. So again, I want to thank you for joining us. I want to thank you for all you've done to bring this important trial to the national stage. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily represent the National Institutes of Health. Thank you for tuning in, and happy clinical trials.